Siegel, the chair of the Medical Review Committee, and I'll be providing an update today on our recent network activities. Although many of us couldn't wait to close out 2020 and look to better times ahead, we managed to do a lot of important work in the midst of the pandemic, and so it's important to take a few minutes now to celebrate our successes and discuss the challenges we faced during an unprecedented year. I'll take a few minutes to review some of the characteristics of the Midwest Kidney Network and features that make us a little bit different from other renal networks around the country. We'll then spend some time talking about our network responses to COVID-19. Next, I'll present results of our quality improvement projects, which we continued throughout the public health emergency. And finally, we'll spend a few minutes talking about what to anticipate in the year ahead. Growth of kidney failure continues over the past 10 years. And in this slide, we can see that back in 2009 and 2010, that the number of patients with kidney failure in Network 11 was right around 40,000. Over the past 10 years, this has grown to 50,000, so about 2.5% per year. As of November, in 2020, Michigan Kidney Network serves over 51,000 patients. What's striking is that over 40% of our patients with kidney failure have a kidney transplant, which is among the highest rates in the country. We excel in preemptive kidney transplants in particular, as well as living donor transplants in general, with almost a 50-50 split between deceased donor and living donor transplants. On the dialysis side, where there are just under 30,000 patients, we have 15% of our patients at home. Of the home dialysis patients, 80% are in peritoneal dialysis and 20% receive home hemodialysis. I point out the home dialysis for three reasons. First, the executive order on advancing American kidney health, which was released in the summer of 2019, envisioned a higher utilization of home dialysis and preemptive transplant than what's typically been seen in the United States. Second, the ESRD treatment choices payment model includes the proportion of home dialysis patients as one of its core measures. And finally, a technical expert panel recently began deliberations on how best to create a dialysis facility quality measure that captures the utilization of home dialysis as a modality option. When I see how Midwest Kidney Network is situated relative to the rest of the country, we're well positioned to meet these challenges and opportunities that lie ahead, but we'll need to pay special attention to access to home dialysis. In this graph, we see the percent of patients with kidney failure who have a functioning transplant by renal network. Networks are along the bottom, and the U.S. average is shown in the red bar at 31%. Network 11 in the yellow bar is at 43%, with only Network 1's percentage being slightly higher. And our rates of patients with a kidney transplant are twice as high as some of the networks on the far right side of the screen. For patients who are receiving dialysis at home, there's less variation across the country in terms of the overall percentages, with most networks ranging between 12 and 15%. Network 11 in the yellow bar is essentially at the national average of 13%. When we zoom in to take a look at the breakdown by states within our network, we have a total of 543 facilities overall. Michigan has our largest number of facilities at 233 and almost 23,000 patients. Minnesota and Wisconsin have similar sized populations with around 130 facilities and 12 to 13,000 patients each. And then the Dakotas with obviously much smaller patient and facility populations in each state. In this slide, we see a breakout of dialysis clinics by ownership. DaVita has the largest number of clinics, shown in the blue segment at just over 200, followed by Fresenius in red at 167. Fresenius has added more clinics over the past year or two, so their proportion has grown the most relative to others. It's worth noting that over 25% of our facilities are either in small regional chains or are independent, which makes us somewhat unique amongst the other renal networks, since we have a relatively large percentage of these small and independent facilities, although that segment has declined over the past several years. When we think about the impact of the COVID-19 pandemic on the dialysis community, I want to start with showing you some of our recent data, which is from the beginning of March. On the far right side, we see rates for the United States overall. The general population is shown in red, and the dialysis population is shown in the blue bars. And we can see that the dialysis population has rates of COVID infection over twice that of the general public. Network 11 is next to that, with slightly lower but fairly similar rates overall as to the rest of the country. These numbers have changed a bit over the past year. Remember that last spring, Michigan was one of the first states in our network to have high numbers of COVID infection. And you can see here that those rates in Michigan have settled back down, but in South Dakota, there are continued high rates, significantly above both the network average and the national average. Over the past year, Michigan Kidney Network has been quite active in providing assistance to dialysis facilities to address COVID concerns. This starts with collecting data on rates of infection among both patients and staff at the facility and state levels. This allows us to identify emerging hotspots in real time and then share that information. We've helped provide technical assistance to dialysis facilities. Most notably in South Dakota, where obtaining personal protective equipment in certain areas was a real struggle. And the network has disseminated information from a variety of sources about COVID. If you haven't seen the Michigan Kidney Network website recently, I really encourage you to take a look. Just type in Michigan Kidney Network to your browser and it should pop up as one of the top choices. This site's easy to navigate, it's got a clean, fresh look, and it's loaded with helpful resources. There you'll find information on infection control issues, vaccinations, and administrative issues. There's information targeted for both patients and providers, and it's your one-stop shop for pulling together resources from the CDC, the American Society of Nephrology, the National Kidney Foundation, and the ESRD National Coordinating Center. Finally, amongst our COVID-19 efforts, we contacted each of our 5 states' departments of health to advocate for prioritizing dialysis patients and staff for early vaccination. Here are some examples of resources to help with COVID that Michigan Kidney Network has put out over the past year. On the left is one of our transportation frequently asked question guide. There's state-specific information for both dialysis providers and patients. Next is our telemedicine tip sheet for patients. It explains what telemedicine is, why you might want to consider using it, and how to prepare for a telemedicine visit. Next, the My Life, My Choice brochure was developed by our consumer committee, and it explains treatment options in clear, easy-to-understand language. While it's not COVID-specific, thinking about treatment options in the midst of a pandemic is important, as we've learned that home dialysis patients tend to have lower rates of COVID infection when compared to patients who receive in-center dialysis. And last, an example of a door sign for dialysis patients can help provide a reminder about symptoms to be mindful of and to stay out if you're not feeling well. I'd like now to review our quality improvement projects that we completed in 2020. We'll review results from our bloodstream infection project, which included both reduction in long-term catheter use, as well as participation in health information exchanges. We'll review our projects to increase both the number of patients that began training with home dialysis modalities, as well as that are waitlisted for kidney transplant. And last, I'll discuss our vocational rehab project, as well as efforts to engage patients and their families throughout all of these efforts. Starting with our bloodstream infection project, which has been a staple of our quality improvement efforts over the years, our goal was to reduce bloodstream infections by 20% from our baseline rate. Here we worked with a little over 100 facilities that had relatively high infection rates to begin with, to make up our cohort. We continue to use multiple interventions for this project that include webinars, monthly coaching calls, education tools from the National Healthcare Safety Network, and shared tools to help patients and providers better care for their vascular access. We shared best practices developed by one of our facilities to help with early identification of bloodstream infections. And our Healthcare Acquired Infection Learning Action Network, or HILAN, brings a multidisciplinary team to aid in these efforts. At the bottom, you can see that this has been a successful project. Our baseline was 1.4 infections per 100 patient months, and by the end of the intervention, the rate was down to 0.6 infections per 100 patient months, a 58% improvement. Here's what the data looks like. On the left is our baseline infection rate, measured from January to June of 2019. And when we look at the right-hand side, which is the same 6-month period for this year, we see a reduction of over 50% in infections. But what's hard to see from a graph like this are the real people behind these numbers that are positively impacted. In this 2020 cohort, there were 253 people on dialysis who didn't have a bloodstream infection that they might have had otherwise if it weren't for these ongoing projects. While some bloodstream infections are treated without complications and people are able to emerge on the other side relatively unscathed, some of the bloodstream infections have awful complications like endocarditis and osteomyelitis that can have devastating long-term sequelae. So not surprising, keeping people healthy saves money, a lot of money. And with the average bloodstream infection costing around $20,000, that means we help save $5 million for our healthcare system. As part of this project, we also had a goal of reducing our long-term catheter rates. In the past, you may remember that when we've worked on this project, it's been similar to our bloodstream infection project in that we would identify a cohort of dialysis facilities that had relatively high long-term catheter rates and then work with that group of facilities to help them improve. This year, we included all facilities in the network, so our goal for reduction was relatively modest, but at a larger scale. We used educational webinars and tools to help dialysis facilities better track the vascular access pathway from catheter use to surgical access. And when the pandemic hit this spring, most all operating rooms were shut down, save for emergency procedures. Even though CMS released a statement that vascular access surgery for dialysis patients was still considered a critical surgery, we saw rates of surgical accesses plummet in the spring of 2020. As a result, we were unable to catch up and meet the goal, and in fact, long-term catheter rates rose across the network and at the national level as well. Here's what these numbers look like. The baseline periods on the left. You can see that we made a small improvement at the end of 2019, but by March, the rates are rising, and they peak in June at 15.3, and then come down just slightly by the time we finished in July. But we're not alone in our catheter struggles. Here's what the rest of the country looks like, broken out by renal network. There's 18 networks, and you can see that we're pretty much in the middle of the pack. The last component of the bloodstream infection project was to help 20% of the facilities in the cohort join a health information exchange. For the last several years, we've had concerns that dialysis facilities are not always able to capture infectious episodes that occur in the hospital setting. But by joining a health information exchange, dialysis facilities have improved access to medical records outside of the dialysis facility. We did meet our goal for this portion of the project and helped 77 facilities join a health information exchange so that they could better identify and report bloodstream infections. Similar to our long-term catheter reduction project, where we transitioned from working with a cohort of dialysis facilities to all facilities in the network, we had a similar structure for our home dialysis project. We had a goal of 5.6% of patients starting with home dialysis. Our efforts focused on helping in-center programs establish good working relationships with home dialysis programs. We promoted early education with a variety of staff education webinars and on-demand presentations and tracking tools to help facilities achieve their goals. We exceeded our target with 6.2% of patients starting a home dialysis modality, which means that just over 2,000 patients are at home who would otherwise be in center right now. And again, here's what these data look like over the course of the year, a nice steady progress towards meeting and exceeding that goal. So in 2020, with those 2,000 patients that transitioned to home dialysis, given that home dialysis is less expensive than in-center treatment, we saved over $23 million to the healthcare system. Our transplant project had a goal of increasing the number of patients added to the transplant waitlist by 2.6%. Again, similar to other projects, all facilities in the network participated, and I'll discuss our interventions in just a minute. But I want to point out that, similar to access surgeries being placed on hold, living donor transplants were also temporarily suspended due to the pandemic, and for several months in the spring, a lot of routine health care, like transplant evaluation, was put on hold as we focused on caring for COVID patients. So while we didn't reach our transplant waitlisting goal, we did come pretty close, and almost 800 patients were added to the transplant waitlist during the project period. We continued to use a variety of strategies to help establish better working relationships between the dialysis facilities and their transplant centers by using liaisons, coordinators, as well as patients themselves. We promoted a variety of tools, some of which focused on education about the steps between referral and waitlisting, as well as tracking tools to better engage the facility in helping patients on this pathway. The network hosted a multidisciplinary work group to help develop these tools and strategies for the project. And then we shared best practices amongst providers. One of the innovations that we developed that I'm super excited about is an interactive web page on our website that helps locate transplant centers in your area. When you click on the pin for a given transplant center, you can see that a pop-up window appears as shown in the slide here, and it typically will have the name and phone number of contact people, often a pre-transplant or intake coordinator. You can check this out for yourself by going to midwestkidneynetwork.org and then /transplant-locations. Another innovation was developing a readiness form for transplant waitlisted patients. We recognize that it's not just helping patients get on the waitlist that's important, but it's helping keep patients on the waitlist and helping them stay healthy so that they have the opportunity for transplant. This questionnaire helps dialysis facilities adopt a transplant center perspective as they think about their patients' overall health. There are questions about recent hospitalizations, use of anticoagulant medications, changes in insurance, and progress towards weight loss and smoking cessation goals. It's a really helpful tool to be able to anticipate future needs for patients as they work towards staying active on the transplant list. If you'd like a copy of the form, please reach out and contact us at the network. Here's what the numbers look like over the course of the year. You can see that the change in the slope of our progress starting in March. And that's when obviously the worst of the pandemic started to hit in the spring. And you can see that that line flattens out through June. By July, things start to get a bit better. The slope of that line improves, but we're not able to make that 2.6 goal. Last, I'm going to focus on our employment project, which had 3 components, and we were able to achieve goals in 2 of those 3 components. We did well in the screening portion for interest in employment services and for the referral portion of the project. We didn't meet our goal for the number of patients who are actively receiving employment network or vocational rehab services. Again, with the devastating impact of the pandemic on the economy, this isn't really a surprise. Michigan Kidney Network has always had a very strong consumer committee and a history of working with patients and their families to improve the process of dialysis care. We have become a beacon for other networks and how to effectively partner with patients for participating in care plans, in the facilities quality improvement programs, or in patient support groups. We have relied on our patients for help and engagement with telemedicine, which was available in 2019, but actually blossomed during the pandemic. The feedback we've received from our subject matter experts on various projects has helped make them better and has been instrumental in the project's success. Ultimately, who better to turn to than patients and their families and care partners when we look to help all those with kidney disease become more engaged in their care. So I'd like to take this opportunity to thank all of the patients, their families, their care partners who've helped make our work at the network more impactful and more successful. When we look at the numbers here, there's been really nice improvement over the past couple years. We have over half of our facilities that have patient support groups available. Last year, that number was only a third. We now have almost all of our patients participating in their care plans, and 3/4 of facilities have patients join the interdisciplinary team in monthly quality assessment performance improvement meetings. Last year, that number was closer to 50%. As we look forward to the current year, I want to remind everybody about the CMS national goals that they want all networks to achieve by the end of 2023. These include a reduction in the national rate of bloodstream infections by 50% relative to the baseline period of 2016. With regards to transplant, the national goal is to have a 30% increase in the number of patients on the transplant waitlist compared to the 2016 baseline average of 18.5%. And last, there's a national goal to increase the number of dialysis patients who receive their therapy at home from the baseline of 12% up to a target of 16%. We'll spend a couple minutes going through our quality improvement activities for the current year. It's going to be a bit different than in prior years. Don't worry, you'll still see some familiar projects, such as ongoing focus on home dialysis and reduction of bloodstream infections, but there's a new emphasis on behavioral health outcomes and outcomes related to complex chronic conditions. You'll see new projects related to reducing hospitalizations, readmissions, and emergency department encounters, and projects that focus on patients who reside in long-term care facilities. For our behavioral health outcomes, we want to focus on our ability to screen for and identify patients who have depression. It's incredibly common amongst patients who are living with kidney disease. And among those patients with depression, we want to see an increase in the percentage of patients who receive treatment by mental health professionals. We're going to be helping facilities report depression screening results in EQRS, and we'll be working to assemble a coalition of high-performing dialysis facilities and subject matter experts to help in this process. There are projects lined up to focus not just on reducing catheter infection rates, but specifically focusing on patients who receive dialysis care within nursing homes. Similarly, for the small number of patients that receive peritoneal dialysis in a nursing home, we'll be targeting reduction in peritonitis rates there as well. We'll be looking to identify facilities that provide care for patients who receive dialysis within a nursing home. And again, we're putting together a coalition of high-performing subject matter experts to help in that process. We will continue our work in promoting home dialysis, which continues to be underutilized across the country, focusing on both increasing the number of patients who start using a home modality, as well as the number of patients who switch from in-center to home. We'll also work to help increase the number of rural home dialysis patients who can use telemedicine as part of their home dialysis care. I think that's going to be a really exciting portion of this project. Similarly, we'll continue to promote kidney transplant with projects aimed at increasing the number of patients waitlisted and increasing the number of actual transplants performed, and promote telemedicine as part of this entire process. There'll be emphasis on making sure that we effectively utilize high kidney donor profile index, or KDPI kidneys. These are kidneys that, while they might not last as long, can still provide improved quality of life and longevity to patients who might not otherwise have the opportunity for transplant. With regards to COVID, there's going to be a push to make sure that 80% of dialysis patients receive the COVID vaccine, and will continue to promote influenza and pneumococcal vaccines. For the first time, we'll focus on reducing hospitalizations for specific diagnoses like fluid overload. We'll include readmissions and emergency department encounters as well. The ESRD Seamless Care Organizations, or ESCOs, have demonstrated that this can be done, and sometimes with relatively simple, low-cost interventions. Finally, we'll work to reduce the number of blood transfusions in patients who receive dialysis at nursing homes. As well as we've done with integrating patients and care partners into our quality activities, we know we can do even better. We'll work to increase the number of facilities that integrate patients and families into quality assurance meetings. We know that we don't talk with patients enough about developing a life plan and how dialysis fits into that life plan, and so we're going to work on that as well. And finally, we're going to expand peer mentoring, a critical part in this whole process. As many of you know, EQRS, the ESRD quality reporting system, has become the replacement from Crown Web. We'll be working with facilities to improve the speed at which information is entered, such as hospitalizations and information from the CMS 2728 and 2746 forms. The network has developed an EQRS frequently asked question sheet to help provide education and support in data entry into both NHSN as well as EQRS. There's a glossary of many of the terms that we throw around, which have become a literal alphabet soup. So I'm just going to run through these quickly so you can see if there's any questions for things that you didn't catch along the slides along the way. And finally, in summary, we've been successful in our quality improvement projects for 2020, and we have an aggressive agenda on the table for the upcoming year. I'm confident that we'll continue to be effective in improving the quality of care that's delivered. On behalf of all the staff at the Midwest Kidney Network, I'd like to thank you for everything that you do day in and day out to improve the care of patients who are living with kidney disease. Thank you.